Imagine this. You wake up in your bed. You can see your room and you know where you are. You can hear things around you, but when you try to move, nothing happens. Your chest feels heavy, like something is sitting on it. And you try to scream, but no sound comes out. And then, to make it worse, you notice a dark figure standing in the corner of the room, staring at you. Is this a demon? Are you in a horror movie? Is this a satanic curse? This is sleep paralysis. Sleep paralysis is a temporary state where your brain is partly awake, but your body is still paralyzed in the sleep mode. You cannot move or speak, and it is often accompanied by intense fear and very vivid hallucinations, like seeing intruders, feeling pressure on your chest, or sensing that something is in the room with you. To understand why this happens, we need to talk about what your brain normally does during sleep, especially during a stage called REM sleep. REM stands for rapid eye movement. It is the stage of sleep where most of our vivid dreaming happens. During REM sleep, something very important is occurring. Your brain is highly active, almost like you are awake, but your body is shut down. Almost all of your skeletal muscles you normally use to move voluntarily, are temporarily paralyzed. The paralysis in REM sleep, called REM atonia, is produced by a specific brainstem spinal inhibitory circuit that suppresses spinal motor output while dream-related cortical activity continues. A key structure in this circuit is the dorsolateral pons within the sublateral dorsal nucleus. Neurons in this region show elevated activity during REM sleep and provide excitatory input to downstream inhibitory premotor networks. From the pons, this excitation is relayed to inhibitory neurons in the ventromedial medulla, which is part of the medullary reticular formation. Many of these medullary premotor neurons release GABA and glycine, and they project down to the spinal cord to suppress motor output. At the spinal level, inhibition targets alpha motor neurons both directly and indirectly via interneurons. The immediate effect is a strong inhibitory postsynaptic current in motor neurons, mediated primarily by glycinergic and GABAergic transmission, which hyperpolarizes motor neurons and lowers their excitability. This is reinforced by a parallel mechanism. During REM sleep, there is a marked reduction in tonic excitatory neuromodulatory input from monoaminergic brainstem nuclei, especially noradrenergic neurons in the locus coeruleus and serotonergic neurons in the raphe nuclei. This withdrawal of motor neuron facilitation makes the spinal motor system less responsive overall. Put together, REM atonia is best described as active inhibitory drive onto spinal motor neurons combined with reduced monoaminergic facilitation, producing a state where the cortex can generate movement-related content in dreams, but the final common pathway, spinal motor output, is strongly suppressed. So, now you may ask, how can we still move our eyes? After all, we're in REM, so where are the rapid movements coming from? Well, extraocular motor control is preserved, so the oculomotor system remains capable of generating saccades. Breathing is also preserved because the diaphragm, driven by phrenic motor neurons at the C3 to C5 level, continue to receive adequate respiratory drive, even though other respiratory muscles, like the intercostals, may show reduced tone. That combination can make breathing feel restricted or effortful during sleep paralysis, even when ventilation is still occurring. In sleep paralysis, the major problem is the state dissociation at the REM-wake transition. Cortical networks supporting awareness return toward wake-like function, but the pontine medullary inhibitory pathway and the reduced monoaminergic facilitation have not yet fully disengaged. The person becomes conscious of their environment, while the spinal motor system remains suppressed, meaning awareness is restored before voluntary movement is. Because your body is paralyzed and you're not getting normal feedback from moving and touching your environment, your brain may try to make sense of this conflict by filling in the gaps. This can produce the sensation that there is an intruder or presence in the room, or the feeling of pressure on your chest, which some people interpret as a creature or figure sitting on them, or even out-of-body experiences where you feel like you're floating above your own body or looking at yourself. Most people will experience sleep paralysis in their lifetime, but the good news is that sleep paralysis episodes are usually short and not physically dangerous, although they can feel awful at the moment. While no specific treatment exists, doctors often recommend improving sleep hygiene. This may involve avoiding caffeine and alcohol late in the day, having a consistent sleep and wake-up time, and not using screens before bed. If sleep paralysis is particularly distressing, cognitive behavioral therapy can be an effective avenue to alleviating anxiety around sleep and improving outcomes. As well, of course, understanding the neuroanatomy can be surprisingly comforting. If you wake up one day, unable to move, and you feel a presence in the room, what you're experiencing is just your own brain mistiming the shutdown of REM sleep. And once you know that, the monster in the corner becomes a bit less powerful because you understand that it was created by your own sleeping brain. Interestingly enough though, people with narcolepsy tend to experience sleep paralysis more often. And we'll get into narcolepsy in the next part of this video.